Okay. How about now?
Good.
And now you'll unmute me. Okay. Thank you. Yeah, that was among the things I learned from Shirley. Might could was the other one. I wasn't from a part of the country that used double conditionals as a way of speaking.
All right, good afternoon. Wow, you all are so good. The moment I said that, you all just quietened down. It's great to see you all. All right. Now, this is just a guest appearance this afternoon. You'll see the real me tomorrow, so whatever you see, just scratch it out. Welcome to Cedar Lane and to the Kiplinger Lecture on Ethics for 2025. I'm the Reverend Abhi Janamanchi. My pronouns are he and him, and I have the honor of serving Cedar Lane as the senior minister. Whoever you are, wherever you're from, and whomever you love, and whatever your gender identity, sexual orientation, life circumstance, documentation status, disability, or political affiliation, you are welcome here. We're delighted that you made time to join us for this important event. And for those who are joining us online, a special welcome. We're so glad you're joining us. I know there are some groups that have been formed in some of the communities, so it's wonderful to have both in-person and a virtual audience for today's lecture. Now, for those who may be new to Unitarian Universalism, I just want to share a little bit about who we are. Unitarian Universalism is a practical, covenantal, and prophetic faith. It is practical in that our religious practice evolves as we grow in understanding and take responsibility for shaping our beliefs and our values. It is covenantal, grounded in the promises we make with one another about how we will be in religious community. Central to these promises is the acknowledgement that we will make mistakes, that we have faith in the possibility of forgiveness, and trust that we can move even closer to creating the beloved community. And Unitarian Universalism is prophetic in that we are called to respond to the moral challenges of our time with courage and conviction. Our faith demands that we uphold justice, equity, and compassion, and that we advocate for ethical values that foster the dignity and worthiness of every individual. It is this commitment to ethical values and principled action that brings us together today. The Kiplinger Lecture on Ethics serves as a powerful expression of our dedication to exploring, understanding, and applying moral principles in our world. And through these conversations, we seek to inspire and challenge one another to live with greater integrity, responsibility, and awareness. The Kiplinger Lecture on Ethics in American Society, now in its 24th year, exists thanks to the generosity of the Kiplinger Foundation in memory of Willard M. Kiplinger, a founding member of Cedar Lane and the visionary behind the Kiplinger Washington Letter. Willard Kiplinger was not only a renowned journalist, author, and editor, known for his incisive analysis of the national government's effects on the economy, but also an active Unitarian and a devoted philanthropist. He founded the Kiplinger Publishing Company, which introduced the Kiplinger Letter and Kiplinger's Personal Finance magazine. His philanthropic legacy included early support for educational television and WETA. His son, Austin Kiplinger, continued this tradition of giving and honored his father's commitment to ethics and education by establishing the endowment grant that funds this annual lecture at Cedar Lane. We're especially grateful for the Kiplinger family for their continued generosity and commitment to this meaningful program. We're delighted to see Mr. Austin Knight Kiplinger and his wife who are joining us this afternoon. Thank you so much for being here in person. And those of the Kiplinger family joining us in spirit, their dedication ensures that this lecture continues to foster critical conversations on ethics and morality. And finally, I wish to recognize the 2025 Kiplinger Lecture team, whose hard work has brought this program to fruition. Kathleen Nepper. Kathleen, would you please rise? Peter Henderson, Sandy Shaw, Peter Fenn, Judy Schaefer, Ron Uten, John Gubbings, and former member Peggy Jackson are all here. Thank you all for your hard work and dedication. We're also grateful for the excellent support from the Cedar Lane staff in making this lecture possible today. Now, it is my pleasure to welcome Sandy Shaw, who will introduce our distinguished speaker.
Thank you, Abhi. My pronouns are also he and him. I'm both honored and delighted to introduce this year's speaker. Dr. Jeffrey Kahn is the Andreas C. Dracopoulos Director of the Robert Henry Levi and Rita Heck Levi Professor of Bioethics and Public Policy at the Berman Institute of Bioethics at Johns Hopkins University. That's a mouthful. He's also professor in the Department of Public Health Policy and Management in Johns Hopkins Bloomberg School of Public Health. He works in a variety of areas of bioethics, exploring the intersection of ethics and health science policy, including human and animal research ethics, public health, and ethical issues in emerging biomedical technologies. He has written extensively and spoken internationally. What's more, Jeff is a good guy. It's been a real pleasure working with him to get us to this afternoon. Dr. Kahn will answer questions after the talk. Please raise your hand if you need a note card to ask one.
Thank you. This working? Yeah, good. That last part about being a good guy was not the bio that I sent, just to be clear. I appreciate the kind introduction and all the work that you have done in preparation. I will say, in getting ready to come here today, I watched the YouTube of last year's Kiplinger lecture. Thank you to the family for endowing this wonderful series. And a couple of through lines from last year to this year, which you probably wouldn't know about. One, I taught for 5 years at the Medical College of Wisconsin before I went to the University of Minnesota, which Kathleen, you remember, I'm sure, and Rusty Feingold was my senator. So I was really pleased to see that he was sitting on the stage here talking to Dean Tolson. Not so happy about Dean Tolson, but not for reasons that you probably would understand until I say, I'm a proud alumni of UCLA, and Dean Tolson is the dean of the law school at USC, which is our big rival. So anyway, connections across the years. I'm really pleased to be here, and I will say too, Reverend, your comments about the mission of your church and congregation and universalism could not be more important. As we stand here today on what feels like the precipice of lots of problems, but among them, a big part of that is about ethics. So it feels a little trite in some way, but I'm going to talk about a case, a story, and maybe take our minds off of what's going on in the world around us. It's a story that isn't, turns out, from today, but it resonates, I think, not only from when it happened, but today and going forward. It's about, as the title of the talk says, about genetic engineering in a way that might be a little surprising to you, but I hope you'll find it intriguing. It's a real story, one that I was involved with while I was on the faculty at the University of Minnesota. And it's important to say, before I start in here with the slides, I'm going to talk about the medical conditions and diagnoses and prognoses of actual patients. I'm going to show you their pictures. I'm going to tell you information about them, all of which is in the public domain. Obviously, as someone who does ethics for a living, we don't talk about people and share their private or confidential information without their permission. All of what you're going to hear from me is in the public domain. I was there for much of it, as you will hear, and so I have a kind of firsthand version of the story to share. I know that Sandy said I would wait till the end for questions, but I also am willing to talk with you as we go, and you'll understand why. I may ask you a few questions as we go, and I don't want you to sit and wait. I want you to actually answer if I ask. So let's have that agreement. Okay, so you can all see the slides, I hope, right? I can see them, you can see them? Good. All right, so this is a story about a child who's born with an inherited genetic disease. Anybody a physician in the audience? Good, nobody is. That actually helps me a lot because no one will, oh, there is one, shoot, almost. What kind of physician are you? Retired. Oh, well that, okay. Do you happen to do hematology, oncology, is that your area? No. Good. Okay, that helps. No, so you didn't hear my training. My PhD is in philosophy, which I did at Georgetown University. So I was in DC for a long time. My undergraduate degree is in molecular biology. I did science first. Was planning to go to medical school until I did phlebotomy, drew blood from patients in the hospital at UCLA, and hated touching people who were sick. So I ended up, as a 19-year-old, deciding my life's path based on being queasy at 19, but ended up doing philosophy instead of medicine. Much to the chagrin of my mother, but she's since gotten over it. The point is, I'm going to tell you medical information, and sometimes it's helpful, actually, to have somebody who does this kind of work for a living if questions come up. I've talked about this particular case a lot, so I know a lot of the details, but that's why I asked whether there were any medical professionals in the audience. Okay. So Fanconi anemia is an inherited genetic disorder. This is going to take you back to high school or maybe early university biology about how recessive genetic diseases are inherited. It happens like this. In order to be affected by a recessive genetic disorder, both of your parents have to be carriers or have the disease themselves. And so that means they pass it on, right, to the offspring. And the way offspring assort, this is straight Mendelian genetics, is 1/4 of the offspring, so 1 in 4 chance in every offspring that they will not either be affected or be carriers of the genetic mutation like their parents. Half, 1 out of 2, will be carriers like the parents, but not affected because it's a recessive disorder. And then the problematic 1 out of 4 who get the bad gene from both parents, and then they have the disease. Okay, you know all this. What is important for the story is that children who are born with Fanconi anemia, this inherited genetic disorder, have a range of physical medical problems. One, dysmorphologies, which is a fancy way of saying they have some issues related to how their bodies have developed. They lack thumbs, they have frozen joints in the wrists and other parts of their body. They have incomplete gut, often, which needs to be repaired and can be repaired by surgically. Those are not life-threatening. The thing that's a problem is that by the age 6, 7, depending on the particular mutation, relatively early in life, they develop leukemia. That's why I asked if anybody was a hematologist oncologist, right? So this is a disease that has to be treated as other leukemias are. We used to only do that by something called bone marrow transplant. Anybody? Okay, you are nodding, some of you. And then starting about 25 years ago, really maybe even a little less than that, the cells from umbilical cord bloods when babies were born were collected, and now our many babies' umbilical cord bloods are collected and stored. They're banked, and the cells in the umbilical cord blood, a very few of them, but enough to make a transplant, are the same cells as are in bone marrow in all of our bodies. How does that happen? When a baby is about to be born, right, in utero, all of the blood is circulating. When they are born, take a breath, that's a signal to the stem cells that are circulating in the body to go to marrow. So there's an interesting signaling that no one really understands about why or how, but that sends a message to the stem cells to go to marrow. Some of those stem cells get trapped in the umbilical cord, and so they can be collected and infused, as would the cells that are harvested and purified from a bone marrow donation. All right, so we used to say it's a bone marrow transplant. Now we call it a hematopoietic stem cell transplant because you can use either bone marrow or cord blood. Hematopoiesis means the cells that make the blood system. So a hematopoietic stem cell transplant can be achieved either of those two ways. What's important and relevant to this story is that the people who are the donors to those who need these kinds of transplants have to be genetically related, closely enough genetically related to the individual that they won't reject the transplant. So it's measured by something called HLA, as it says here, human lymphocyte antigen, and the people who are most closely connected or have the closest HLA match to you are the people who are most closely genetically related to you. First and foremost, your siblings, right? The people who are most closely related to you are your sibs, followed by other blood relatives, and then if there are no sibs or no blood relatives, then strangers are asked to be donors. So at the time of this particular story, very early on in cord blood transplant, almost all of the donors were adult marrow donors. Anybody here signed up to be a donor through the National Marrow Donor Program? Do you know about that? Very important organization, the NMDP. When I lived in Minneapolis and taught at the University of Minnesota, I was on the board of the NMDP. I recommend it highly. It's a way for you to save somebody's life without a terrible intervention on your own body. At the time of this story, as I said, almost all the donors came from the NMDP. Now there are huge numbers of cord bloods that are banked and ready to be used for transplants. All right, so if you need a transplant, like a child who's born with Fanconi anemia, when they start to become leukemic, you need a donor. So you need a donor that's either a family member, preferably a sibling, none available, then you go to the stranger pool. Clear so far? Okay, no hands, no questions. Great. Second part of the story, which is important for us before I get to the actual people, is a different technology. So we talked about stem cell donation from either bone marrow donors or cord bloods. This is a photograph, upper left, I think as you're looking at, yeah, same as I am, is an actual photograph under high magnification of a human in vitro embryo. So a human embryo in the laboratory, held in place by a pipette, the sort of reddish brown thing on the left is a pipette that's holding that embryo in place. And then on the right is a finer pipette. I'll tell you what it's doing in a second. That embryo is 8 cells large or 8 cells old. And the cartoon on the lower right part of that slide shows you sort of what's happening. You make an embryo by one egg being fertilized by one sperm, right? That's a fertilized egg which begins to divide, first into 2 cells, then into 4, then into 8. So three divisions post-fertilization, you get an 8-celled embryo, which is what that photograph is of. Very early stage. At this point in development, all of the cells in that embryo are totipotent. They can become any other kind of cell in the eventual organism, in this case a human. It's important because what's happening in the very small pipette on the right, the finer pipette, is there's a cell being extracted. It's being sucked out. Can you see it? So it's effectively a biopsying of a developing human embryo at the 8-cell stage. This is smaller than the point of a pin in real life, so it's highly magnified. All right, and so what's important about this is you can take 1, sometimes even 2 cells, as that cartoon below shows, away from those 8, and the rest that are left just go about their business and keep dividing and fill in the gaps that have been created by taking out 1/8 or 2/8, 1/4 of the entirety of the cell population. It's kind of crazy, but that's what's happening. Why do this? Because you can take the DNA from the cells you extract and test them. You can do genetic testing on the cells, because all the cells have the same genetic makeup, and you'll know the genetic composition of those embryos. And you can make a decision about which to implant in a woman's body based on the answer, like what is the genetic makeup. Okay? Also clear? This is called pre-implantation genetic diagnosis, or PGD. You'll see it on the next slide, so keep the acronym in mind. All right, so one part of the story is Fanconi anemia. Second part of the story is PGD. Question?
Is that PGD routine or is that optional?
Note, well then, so the story I'm going to tell you started in 1999. So at that point, it was quite early days. It's a good question. It's offered more consistently now, but it costs more. It also, there's some risk. You are extracting some of the cells that you don't want to damage. So it's still optional. I think it's done a lot more frequently than it used to be, and it's a way of, if you really want to understand the genetics of the embryo, it's the only way to access that. I think that's what you were asking. Close enough. Okay. Yeah?
So how would this fall into the category of fetal wastage that some might claim is illegitimate uses of cells that could progress to?
So I didn't hear into the category of
Fetal wastage.
fetal wastage. I don't know that term.
Killing embryos in order to do
Yeah.
exploratory.
No, so you're right. It's like embryo destruction is sort of, I think, more what I think you're suggesting. The idea here is not to destroy the embryo. The idea is to actually implant the embryo once you understand the genetics of it. So the hope is that you will not destroy the embryo. However, when you do this, you're making a decision based on what you learn about which to implant and therefore which not to implant. And so part of the story, you're presaging where we're going to go here, is, well, what happens to the embryos that are not implanted, and what do we need to think about that? Okay, so you're on the right track. Okay, so I'm happy to do what we're doing. I like that you're asking me questions, and I will keep us on track, I promise. Any others before we get into the actual meat of the story? All right, so I'm going to tell you a story about this family, whose names are Nash, as it says here. The mom's name is Lisa, the dad's name is Jack. They have a child, their first child, named Molly, who's born with Fanconi anemia. So this is a case where the two parents were both carriers, did not know that they were carriers. And remember I showed you on one of those earlier slides the assortment, 1 out of 4, 1 out of 2, 1 out of 4. So they were unlucky and that the first child they had was the 1 in 4 that inherited the mutation from both parents. It's not, you know, it wouldn't predict it, but it's obviously 1 in 4 chance. And that's what happened with them. So she showed up at the University of Minnesota, where I worked at the time, because the doc that was treating her, well known in this field, a guy named John Wagner, a friend of mine then and still is sort of one of the world experts in treating children with this disease. So this family lives in Denver, Colorado. And you tell you a little bit of the background. The mom, Lisa, is a pediatric ICU nurse, so very familiar and part of the healthcare system, familiar with and part of the healthcare system. The father, Jack, is part of his family's business, and which is they own a chain of hotels in Colorado. It's a wealthy family and very connected in terms of the healthcare system and very a lot of insight about how the system works. Both those things are very important for the story, which I'm going to spin out for you here. They, as I said, had not had any children before Molly. They realized that she was going to face a number of issues that were not going to be straightforward, and the leukemia, of course, would be life-threatening. So they wanted to have more children, but they didn't want to have more children who would be affected. So at this time, PGD was not super rare, but it was mostly used only for families who knew that they were going to be at risk of passing on a genetic disease, mostly cystic fibrosis, because that's the most common inherited genetic disease. And so they were offered the opportunity to use PGD to make sure that the next child would not have the mutations that Molly did. Okay, so using PGD, like I showed you on the last slide, to identify embryos in vitro. Molly was born the regular way, but they would go through the process of making embryos outside the body, testing them, and deciding which to implant. However, they figured out, one, that they could either do what I just said, or they could go through the process of getting pregnant again and then make a decision after prenatal testing about whether to continue the pregnancy. So if Mrs. Nash got pregnant again with a fetus that had the mutations, as did Molly, they would need to make a decision about a termination, an abortion. But then they figured out they could use PGD in the way that I just said, but also in a novel way, which had never happened before. This is where the story gets really interesting. So they lived in Denver, still live in Denver, and they sought IVF there at a very well-known clinic. They said to the IVF clinic in Denver, we want to make embryos outside, we want to make embryos for the purpose of testing them. I, Mrs. Nash, don't need to use IVF to get pregnant, but I want to do it this way so that we can test the embryos. And the IVF clinic was willing to do that. The curveball that the Nashes threw to the clinic was that they wanted not only to test for Fanconi anemia, they wanted to test the Fanconi negative embryos for HLA compatibility with Molly, so that they could identify an embryo that was not only Fanconi negative, but could be a cord blood donor to the sick daughter. Okay, so this was the first case in the world of what became known as savior siblings. So an attempt to make a child that would be a donor to save his or her sibling's life. Okay, so that's the novelty here. This slide is just in words what I spun out a little bit in explanation. So they proposed to do something novel. 2 stages of PGD, identify embryos that were FA negative, and test the FA negative embryos a second time for HLA compatibility with Molly. The IVF clinic in Denver said, we will do Fanconi testing, but we won't test a second time. They refused to do it. We can talk about why in a second, but they were not comfortable with that. And so the Nashes found a clinic in Chicago. So when I talk about this story, internationally, which I have done recently, they don't have a sense of the Denver, Chicago, Minnesota, but you all do. So the embryos were made in a laboratory in Denver, Colorado. A technician was flown from Chicago to Denver to do the PGD biopsying that I showed you, and that technician took little vials with the cells from Denver back to Chicago where the genetic testing was performed, and then phoned back to Denver to say, in this round of embryos, only number 3 is the right combination, implant that one. They had to do that 5 times to get the right combination of genetics and a successful pregnancy. So as it says here, 5 cycles to achieve a pregnancy with a matched embryo. A Fanconi negative matched embryo. They made 27 embryos. To your point about whatever you call it, excess embryos, well, they only used 2. They implanted 1 that didn't result in a successful pregnancy. The second of the 27 did, so they made 27, used 2. That's it. Yeah.
What kind of time frame are you talking?
Good question. So if anybody's familiar with the IVF process, you don't go through this, 1 week we'll do a harvest and make embryos and test them, and if it doesn't work, come back the next week. It's much more protracted than that. It requires hormones and drugs that makes the woman hyper ovulate so that more eggs can be collected than would typically be the case in a month. You have to wait, obviously, at least a month, and it's unpleasant to say the least. It's expensive, you might want to know. And so this took many months to be successful, which is important for part of this story. Just because I said it costs a lot, at the time, $20,000 per cycle to make embryos and test them. Times 5, 20 times 5, $100,000 cash money after tax out of pocket. Remember, I told you that the family, pardon me, was both connected and well-to-do. They then and now own a Learjet, so they could manage the costs. It's important for the story, it turns out. Okay, the baby born from the successful pregnancy, as it says, was born in the summer of 2000. I'm you're sitting in a church. You should not have to be asked this question, but the parents named the child Adam, right? Knowing that he was brought into the world in the way I just mentioned, his cord blood would be collected and used to save his sister's life. At least that was the hope. So why is Adam an appropriate name? Believe this, I asked this question in front of a lot of audiences who have no clue, to be honest. You I'm sure, are not such an audience. So it's a little freighted, right, to say the least, that you would name your child, in this context, Adam. But baby boy Adam was indeed born in Denver in August of 2000. His cord blood was collected and flown to the University of Minnesota on that private Learjet that I mentioned to you. And the family followed. The stem cell transplant with that cord blood happened, as it says here, in late September of the same year. And the measure of success is whether at 100 days post that infusion, the cells have engrafted, and it was announced 100 days later that the cells had engrafted, and Molly's bone marrow and Adam's bone marrow was exactly the same. So it had worked. So success. They returned to Denver January of the following year. Okay, I'm going to show you a couple of photos, maybe 3, and then we're going to talk about ethics. So this is a photo that ran very widely. If you were around in this period of time, you may have actually seen it. It was taken by a photojournalist in Minnesota. Kathleen should answer this question because she's from Minnesota. It was taken in a pretty prominent place in the Twin Cities. Do you recognize the background?
Mall of America.
Indeed, the Mall of America. Inside the Mall of America is an amusement park. At the time, it was Camp Snoopy. It's now got a different name. Do you know?
That all happened
Okay. It's now called SpongeBob SquarePants Park. So inside the Mall of America, which is on the footprint of what had been the baseball stadium, is an amusement park. So inside of the mall is an amusement park, and you can see in the background the merry-go-round, the carousel. And so this was taken before Molly went into the hospital for her last round of chemotherapy and radiation in preparation for the transplant. And they asked her, what do you want to do? She said, I want to go to Mall of America. So that's Dad, Jack, that's Mom, Lisa, Molly there in the middle, and baby Adam is on her lap. You can see in this photo that Molly has a kind of a misshapen wrist and no thumbs. Maybe it's too small from where you're sitting, but just to say, features of Fanconi anemia. Okay, so that's one. You know the outcome, so I'm not spoiling it by showing you this picture. This was a photograph that ran in the magazine, the monthly magazine of Denver, which is called 5280, Mile High City, like our Washingtonian or Baltimore Magazine, the Denver version of that. And obviously these are the same children some years later. So there's baby Adam is now, 5 or 6 years old. Molly 5 or 6 years later. So the miracle of Molly. It all turned out to be a happily ever after story. I'm sure some of you have read this book. Yeah? Or seen the film. Not great literature, but it was a New York Times bestseller. I would say it's not a great book. It was a worse movie. It was not a good film at all, but it was taken from the story that I've told you and turned into a fictional account. So Jodi Picoult interviewed Dr. Wagner, who I mentioned, interviewed the Nashes, interviewed me, and said she was going to write a book about the heroism of parents doing everything they could to save the life of their sick daughter. The story, I won't ruin it for you, it's an old book at this point, so if you haven't read it, this spoiler alert's long gone. The story is not the happy outcome that I've told you about the Nashes. In the book, it's two daughters for one, but the young daughter just becomes a parts factory for her older sister until she can't take it anymore, hires an attorney and sues her family to stop their taking parts of her body to save her big sister. So it's sort of the off-the-rails version of the story that I have told you. Okay, now we're going to shift to the ethics part. Any questions about this? We've done a little bit of the backstory. I've given you the Nash case in very high-level overview, shown you some photos of the actual people. Now we're going to talk about ethics. So any questions before I do that? Yeah?
You're not talking about...
Oh, sorry.
You're not talking about parts, though. You're just talking about the umbilical cord.
In the real case?
Yes.
Have you read the book?
No.
It gets to parts. So it'll come up later in the slides, but since you asked, I will say it now. So among the things that, even in a successful outcome like I've shared with you, in order to survive the transplant, you need to be immunosuppressed, right? You need to take drugs to manage that over the course of your lifetime. Those drugs are toxic to other parts of your body, like your kidneys. And so there's an expectation, hasn't happened yet so far as I know with Molly, but she may at some point need a kidney transplant. And if that were the case, who's a good kidney donor, except the person who was a perfect match. And so in the Jodi Picoult story, versions of that spin out much closer in time. It's a novel. Yeah.
Kind of difficult to see the smaller picture, but
Yeah.
how well did the treatment work for Molly? What was the outcome?
What was
The outcome.
for Molly?
Yeah.
She's fine, although fine is relative for people who have Fanconi anemia. Yeah. So again, this is not secret. So first of all, kids who were born with Fanconi anemia didn't generally live. So very fine by comparison to what would have been the case 10 years before. However, whomever asked me about 5 cycles of IVF over what period of time, among the things that happened in the course of all of the trying was that Molly got sicker and sicker. And the doctors, John Wagner and his colleagues, kept saying, we can't really wait any longer. We're going to have to get a stranger donation because otherwise she's going to die. And they kept doing more chemotherapy to keep the leukemia at bay and radiation, causing her to become sterile. So this, again, feels like it shouldn't be something we talk about, but it's not a secret. So that's a trade-off. Yeah. The other thing, which is a feature of Fanconi, which wasn't known at the time, is that it is a BRCA variant. So you know BRCA1 and 2, BRCA, which is breast and ovarian cancer gene, is also Fanconi. And so that means she and her mother and the female relatives in that line all have BRCA. So they have a risk of breast and ovarian cancer, as does Molly. So survived the leukemia, but not out of the woods, I guess is the very short answer. One more from Kathleen, and then I'm going to keep going. All right, two more, but only two more. Okay.
This may come up, but who owns this umbilical cord?
Great question. I probably should repeat the questions for both for everybody here, but also for the stream. Who owns the umbilical cord blood? So in the case of this story, the family. I mean, so it used to be. I don't know how many of you, have children, but when my children are 32 and 29 years old. When our boys were born, no one asked us about collecting and keeping the cord blood. It was medical waste. So the fact that it has value is relatively new. There's two paths. One is you can donate it, as you would like blood, to a bank, and that's mostly what happens, and they're frozen and used in the ways that I've described for people who need them. The other option is to pay to bank them yourself, which turns out to be not a good idea, because if you, it's a kind of a taking advantage of parents who are being told it's an insurance policy for your children's health. But if your child needed a cord blood transplant, you would not want the cord blood that was theirs because that's why they're sick. It wouldn't make them well, right? So it's actually doesn't make any sense logically, but of course people don't understand that. And so there are companies that charge people to store cord bloods when their babies are born, and you pay a initiation fee and a yearly storage cost. So it's yours to do with as you choose. You could also throw it away if you wanted. You didn't want it to be used by anybody. The woman's, I should say. Okay. You said you weren't going to ask a question. There's one over there.
Okay, well, go ahead and use this then.
Go ahead.
Okay. We're not talking about the boy.
Yeah, we're going to talk about the boy.
I wondered.
Yeah, okay, we're not talking about the boy, Kathleen said, which is, of course, right.
It's a slavery issue.
Okay. We'll get to how to think about him, which is great. Thank you. We're going to get to that, I promise. And then one over here, then I'm going to go back to the podium. Yeah.
Did the Nashes have any more children, or they just...
They did not. So so the question was, did the Nashes have any more children? No, and I'll answer it by saying something a little more than just no. So you remember, because I made a point of it, they made 27 embryos, only used 2. And one of the questions was, what are you going to do with the other 25? So they said, of the 25, some of them are Fanconi positive, like Molly. Those they donated to research. Then the rest were either like the parents' carriers or unaffected, but just not HLA matched to Molly. And they said, we won't have any more children the regular way until we use those first. But they didn't have any more children. So they didn't use them. And so they are, as far as anybody knows, just frozen. Yeah, which is part of the ethics of IVF, actually, because embryos get made and not used, but not usually at the scale of 27. Usually it's a few that remain. And so it shines a light on an issue that isn't of their making, but it's relevant. Okay. Thank you for those good questions. And I'm coming down to, but partly it feels a little Phil Donahue-ish, I expect, but I have a little hearing impairment, so I cannot hear you unless I come and talk to you closely like I just did. All right. So now I'm going to sort of shift to professor mode for a little bit here. And some some questions, but I'll guide us along here. The way that people in my world, and I, over the course of my career, you heard about my background in molecular biology, so I have done a lot of work on ethics and genetics, which until the current moment, the biggest area of funding from the NIH to bioethics work was in ethics and genetics. We'll see what happens with that going forward. But that has been a really important area for bioethics funding and research. And so those of us who worked in that area were really focused on how to think about the use of technologies like PGD and guide it in some acceptable, responsible way. So we asked this question: what are the ways to think about how should we determine acceptable from unacceptable selection of traits when we're testing embryos and deciding which to implant and which not? So the way that we landed was on a pretty straightforward line between these two categories. Pardon me. It's fine to avoid disease in the child that will be born because it's an argument of avoiding or preventing harm to that child. So we don't want another child born with Fanconi anemia or cystic fibrosis. The challenge is, of course, well, what counts as a bad enough disease? But let's put that aside. That was where we tended to focus our attention. How bad is an inherited disease? How bad enough does a disease have to be to justify this kind of selection being ethically acceptable? But we thought the line was really between avoiding disease and selecting for non-disease traits, which you would say, well, I want to select for traits that are not only important to me, but would be beneficial to the child. We don't have the information yet, but to say, if we could test for the genetic predetermination for whether somebody was going to be musically gifted, or the worry is the sort of eugenic one of blue eyes and blonde hair, right? So traits that aren't about avoiding harm, but rather providing benefit. And so we thought the bright line was between those two. If I had a pointer, I would say between avoiding disease and selecting non-disease traits. That was the line that we all were really comfortable with. Then along come the Nashes, who did something that was about selecting both, right, embryos to avoid disease, but also selecting a non-disease trait. But the oddity of it was they selected a non-disease trait that was not for the benefit of the baby we call Adam, but for his sister. It was something that we had not envisioned. It's getting to Kathleen's point. So we were like, oh my gosh, this is where, highly educated and smart people spend a lot of time and your taxpayer money thinking about these things, and yet we didn't envision this. And so it's a little bit of human ingenuity outstripping the creative thinking of academics or something, right? And I told you that the Nashes were both well-to-do and informed and connected. They actually put the pieces together and presented it to the physicians. It wasn't presented to the physician by the physicians to them. Sorry, I botched that, but you got the point. So they figured this out because they wanted to save the life of their daughter. Okay, so we have a kind of twist here that we weren't prepared for and didn't really know how to figure this out. It seems like it falls on the wrong side of a line, but it's in a way that we didn't envision. It's a non-disease trait that doesn't have any effect on the health or welfare of the child that will have it because it's for the benefit of their sibling. So here's a suggestion that doesn't get us very far, I'm afraid, but let me just start with that to say, well, we need to at least say we require parents or expect parents to act in ways, make choices in ways that reflect the best interests of the child that will be born. But in this case, we know the baby Adam, right? He's born without Fanconi anemia into a family that flies around on Learjets, right? And actually is loved and wanted. It's not like he's cast aside. So he's born into a family that wants another child, and while we're at it, let's get a child that will save the life of our sick daughter. And he gets to be brought into the world. So from his perspective, thank you very much. Because if you'd stopped at Fanconi negative, a different embryo would be implanted that was not baby boy Adam, be another child. Maybe they would have called him Adam, but it wouldn't have been the same child, right? So this doesn't get us far enough if we think this raises some issues. So let me connect to the next set of issues. I told you this got a lot of coverage, and the photo I showed you was from a photojournalist who worked for the Minneapolis Star-Tribune, but it ran all over the world. It was really widely covered. My phone was ringing like crazy. It was when we still had phones on our desks. People emailed. We were constantly talking to media. Poor John Wagner, who actually saved small children who had cancer for a living, was inundated. Like, I could do that because my job wasn't quite as important as his in terms of saving lives. But he and I both were constantly on the phone or being interviewed on TV or the radio. And one of the things that the journalists all asked us was, weren't the Nash parents wrongly motivated? Didn't they have a child for the wrong reasons? Getting to your point, Kathleen. So, okay, and that's where our minds go. So I thought about this, as you might expect, for a little bit and said, okay, let's talk about that. If we're going to talk about the Nashes, we need to talk about everybody. Like, why do people have children? Like, what's the motivation for that? And I told you I have 2 sons myself. We want people to say this. So I brought a child or children into the world because of the intrinsic value of loving, cherishing them, making the world a better place, all of the things that you would all say. The bracketed stuff is to invoke standard philosophical approaches. That's from Kantian ethics, if you ever studied Immanuel Kant, who was very fixated, really, on making sure that humans treated each other as ends unto themselves, not as mere means to someone else's ends. That's where we get into this concern that I think Kathleen is starting to point to, okay? And so we don't want people to have children as mere means to their ends, okay? So we want them to be ends in and of themselves. But we also know that people have children for other reasons, like carrying on a legacy. Some cultures that requires a male child, right? And so that's maybe not quite as, purely intrinsic value, but it probably isn't also a mere means to the ends of the parents. What about having more than one child? I have 2, as I told you. My wife and I both come from families of 3. I'm the oldest. My wife is also the oldest. We have middle siblings in both of our families, and we said, gosh, we have to either have 2 or 4. We can't have 3 because we don't want a middle child in our family. It just happened to be my middle sibling and her middle sibling are both handful, and we didn't hands full, whatever way you say that, and we were bound and determined not to do that. Okay. So but that's not a reason for the child so much as it a reason for our own interest, right? So you start to make a list, and you realize, there's some proportion of children who were brought into the world not by plan at all. And we don't tend to say about those people that they somehow were terrible. Many cultures still, certainly historically, had many children in order to work the fields, right? Care for the parents in old age. My maternal grandfather was one of 7 children born on a sheep ranch of Buffalo, South Dakota. That's how they got to the Twin Cities, actually. So why do they have so many children? Well, children didn't always live into adulthood, but they also needed people to work. All right, so lots of motivations around why people have children, and so we have to ask this question. What are the wrong reasons? 1, is the Nash story a wrong reason? 2, and if the Nash story is a wrong reason, what do we do about it? That's the hardest question, and I'm going to play that out now. I'm going to get to the end, so let's make sure. I will take questions now only at the end so I can get through to the last part of the talk. So this is going to push on some of the concerns that I've started to signal and some of the concerns that you have started to show you're thinking about with your questions. People, when they heard about this story, started to come forward with all sorts of strange, what we thought were strange requests, like this one. People called or emailed and said, we want to do what that family did, but we don't want to take the baby home. We just want the cord blood. So we'll put the baby up for adoption. Now, why they would tell you that in advance is a kind of interesting question in and of itself, but people would articulate that as their motivation. Then we get into, well, is that a mere means use of that child? Now, one thing you say is there's nothing wrong with being adopted, right? People who are adopted often have better lives than they would have if they weren't. But it goes to the motivation of the parents, so we have to think about, if that's bad, what do we do about it? Also, turns out you don't have to wait for a baby. It's actually probably 10 weeks. You can get pregnant, do what the Nashes did, get pregnant, abort, collect the fetal tissue, purify the cells from that, and infuse them as you would a cord blood. So for some people, this is worse. For some people, this is better. It depends on what you think about abortion and the use of fetal tissue. It turns out bullet 1 is nothing we can do about it in at least current law and policy. Bullet 2 you cannot actually do. It's against the law in the United States. Going back to the George H.W. Bush administration, believe it or not, there was policy that had nothing to do with this story, but it turns out to be important for this story. Okay, and not to dwell. We can talk about this if you care. So it raises the question then is, should we, and if so, how to assess the motives of parents? We don't do that, right? We haven't done that for a very long time in this country. Do you know Buck v. Bell, the Supreme Court case, which is now 75 years ago-ish, right, where the state of Virginia was forcibly sterilizing women against their will because, as the court ruled, 3 generations of imbeciles are enough. That was upheld by the U.S. Supreme Court. It's not good law anymore, but it was a law of the United States less than 100 years ago. We don't want to go back there, is my point. A little bit of Handmaid's Tale, which feels, unfortunately, closer to being possible than it ever has during our lifetimes, but I'm not here to make political arguments. So, if we just stay with me and say, there's no way we're going to interfere with the reproductive liberty of our fellow citizens. These aren't good enough reasons, even if we, could find a way. We're not going to do that. So we're left with, what about the child? We're finally going to get to talk about Adam. So I got pulled into this story when John Wagner, the pediatrician I mentioned to you, called me one day and said, hi, Jeff, how are you? I said, fine. How are you, John? What's going on? He said, I have a case I want to talk to you about. Great. He said, I have to come to your office, though. I can't talk to you about it on the phone. Okay. Comes over to my office, tells me this story. I thought in prospect, it turns out, I said, so when's this all going to happen? And he said, well, the mom is pregnant. So all those 5 rounds of IVF had already happened, and the pregnancy was underway. And I said, why did you not tell me about this before? And he said, I didn't want you to tell us we couldn't do it. And I said, one, I don't have the power to tell you not to do it. But second, if you want me to help you, you have to tell me before, not after. Okay, so that then led to our getting involved because the institution needed to be ready to figure out what to do. Okay, and so among the things that we started to talk about is, well, you now are pregnant, you're going to collect a cord blood, but there's, some probably high probability the cord blood transplant will not work. And if that happens, you need to make a decision because you've got a very sick little girl and a perfectly matched infant, and you need to make a decision about whether that little baby should be taken to the OR, put under general anesthesia, and a very large needle jabbed repeatedly into his very small pelvis and extract bone marrow from him because he's now the thing that's going to save your daughter's life. And I was in the room when this happened, And the Nash family, rather than taking it as, oh gosh, we better think about that, said, we'll do that. We all were quite taken aback, actually, because they didn't have to make that decision, certainly in the room that day, and not for some number of months, but they were ready to do it. And so then you get into, oh my gosh, wait a second, now we have to think about how much risk to allow a donor to be exposed to when the benefit is not for him, but for somebody else. This is the classic problem we have with the ethics of research on human subjects, actually, because we ask people to participate in research that has some risk for them, almost always for benefit for people who come after them. We know about this, we talk about it. There's a thing called informed consent, which we use, and there's all sorts of evaluation by third-party groups about whether the risk-benefit balance is appropriate. None of that happens here because it's inside of a family. Big challenge. So I suggested that there would be some benefit in having some independent third-party review that would determine whether there was sufficient offsetting medical or it would be psychological benefit to the donor when he couldn't decide for himself. And even if he could decide for himself, the parents are conflicted. I mean, they're in a position to, force him to do what they want. My suggestion was roundly shouted down, not appropriate. The parents get to decide, and that's the answer in U.S. policy, not the answer in Europe. It turns out parents are not allowed to make decisions like that in the context of conflict in other parts of the world, but they are in the United States. So we leave it up to parents to make such decisions. And so the question then is whether there should be any limits. That's the Jodi Picoult novel question. That was what she sort of figured out. There's a little hook there. Okay, so big challenge here because we've got very fundamental, and I'm going to say this again so you hear it, but really foundational commitments in conflict with each other. We've got reproductive liberty, we've got parents making decisions, and we've got doing what's right for people without using them as mere means to our ends. Very hard to square this, it turns out. There's a few reasons why it's even harder than it might look. Institutionally, it's quite difficult, but also from a kind of policy perspective, it turns out to be quite difficult because, you may know, there's a ban on U.S. federal dollars being used in research that harms or destroys human embryos. This goes back to the first Reagan administration, so the 1980s. We're kind of in an environment where this is likely to be something that would happen now, but it's been part of the federal budget every year since 1981. Okay, it's, as it says there, a function of the immediate aftermath of Roe, which of course isn't good law anymore. But there was a reaction to that where somebody decided, and it got introduced in policy, that it was a kind of dirty hands problem. You can't make people who don't agree ethically to allow their tax dollars to be used in unethical research. And so as a function of that, there is no federal research funding for human embryos, research on human embryos. Why is that important? Because in our system, we don't generally make people follow rules unless they take the money from the government. So rules follow money, which is an unusual American civics situation, but it's real. So therefore, this falls between cracks. It's private funding almost always, and there's no required oversight. Second, the insurers don't get involved in the way that you would expect in other areas of medicine because certainly at the time this story unfolded, there was very little third-party payment for reproductive technologies, for IVF and others. So that meant you don't have the insurers saying that's something we will approve. So you've got no federal government oversight. The insurers, whether you like them or not, play a role in stories like this. So they don't have anything to say here. And then the clinics that do this work are not interested really in not doing things. The competition is to do more and do new. And so self-regulation by the reproductive medicine folks, anybody here do that work for a living? It's a very competitive environment of medicine. And so it's a kind of perfect storm. The last thing which made it really hard for us in this story was that the various parts of the story were undertaken in various parts of the United States. They weren't all in even one state, let alone one institution. So the IVF was performed in Denver, the PGD in Chicago, and the cord blood transplant in Minneapolis. So what that meant was everybody could say, I just did this one thing. I didn't do all of it. I'm not responsible for what happened in Denver, right? And the folks in Minneapolis aren't responsible for what the PGD clinic did in Chicago. And so everybody had plausible deniability, quite literally, which meant everybody just said, not my fault. So it turns out this is a 25-year-old story, but it's very, very relevant for going forward in other technologies, and I'm happy to say more about that as part of the Q&A discussion if you want, but it shines a light, has shown a light on the challenges of governance and policy around the ethics of using things like human genome editing, mitochondrial replacement, which is another very high-tech reproductive technology, and others that will come. Two last things. I mentioned this already, but just to reiterate, was a very expensive proposition. I told you it was $20,000 per cycle times 5. It also turns out because of the way the cord blood was created and obtained, the insurers that the Nash family had for Molly's care deemed her care to be experimental, and therefore they would not cover it, literally $1 million out of pocket. They subsequently sued and successfully sued and got that money back, but somebody had to pay literally $1 million out of pocket in order to allow the child to be saved. And the University of Minnesota was not willing to eat those costs. So the family came up with that money. We've already talked about lots of embryos and what happens to those that aren't used. We can discuss that if you wish. And then we get into again, what the journalists really had to say, which is, this is designing babies. Well, no, it's not actually designing babies. It's selecting traits from the embryos that you make. However, we can now design babies. There is, the technology exists to do human genome editing of embryos at the right stage. And I'm going to show you a slide here of a article that was published in, I think that says 2019. That's too small for me to read and probably too small for you. Not important. It's 20 years later where somebody said there was this attempt to do Save Your Siblings that was very clumsy, took a lot of steps. Why don't we now just talk about taking and making an embryo in vitro, doing genetic modifications on it so it's both FA negative and HLA matched to the child you're trying to save? Quicker, more efficient, much more likely to be successful, much cheaper. So we have a technology that would allow that to happen. It, unfortunately, would not be allowed today because it would create heritable genetic modification. The child that would be created that way would pass on those changes to future generations, and so far that's prohibited in our country. All right, last. My institute produces a podcast, which is called, as you see, Playing God, all lowercase with a question mark. Important to say, lowercase and with a question mark. The first season was done in conjunction with Pushkin Industries. We're producing the second season now in-house. If you're interested, it's really interesting, one. But two, episode number, what number is this? 6 is about this story. So if you want to hear some of the people who were involved firsthand, I'm part of it, but the others that I mentioned, it's a 28-minute long episode about this story. All right, with that I will stop. You've been really good about asking and listening, and I don't know how long you'll want to sit, but I'm ready to talk with you now. Thank you. So, Reverend, do you want to, oh, you've got cards. Okay.
Got a few questions.
Great. There's also people who still have hands, but we can do it however you want.
So this question Would you read this quote and question below? The primary moral goal for today's bioethics can be summarized in a single sentence: get out of the way. A truly ethical bioethics should not bog down research in red tape, moratoria, or threats of prosecution based on nebulous but sweeping principles such as dignity, sacredness, or social justice, nor by sowing panic about speculative harms in the distant future. Of course, individuals must be protected from identifiable harm, but we already have ample safeguards for the safety and informed consent of patients and research subjects. That's Steven Pinker in 2015.
Yeah.
The moral imperative for bioethics. And the question is, do you agree with this get out of the way argument? Thoughts?
Yeah. Part yes, actually. And my thinking about the work that we do and that I have done in my career is not about being the, I don't know, an obstacle. I don't remember exactly what the quote says, but effectively being an obstacle. But rather helping to guide the successful and responsible use of these technologies, which I think is what we do well. Interestingly, there have been bioethics efforts that focus on things like dignity and more amorphous kinds of principles that I think do exactly what Professor Pinker is challenging. It's not the kind of work that I do. It's a little bit, painting with a broad brush, say bioethics does or doesn't, because we aren't like, kidney specialists. All nephrologists do, nephrology the same way. So you need to listen to the arguments that we make, and whether you find them acceptable or not, and that's the judgment. Many of us get invited to participate, and I'm lucky to call myself among this group to help guide policy level discussions through things like the national academies and the NIH and other international bodies, because we're not viewed as trying to get in the way, but rather help to facilitate the responsible use. So part of the counter, or maybe the example to support what I just said, was turns out 2015 is the right year. There was an announcement in Hong Kong at a meeting that I attended. It was called the International Human Genome Summit, where a Chinese physician announced that he had successfully edited human embryos. And we were all shocked that he had proceeded in a way that seemed totally counter to all the arguments and principles that had been put in place. And it totally set back the field very substantially. And so one of the things that pushed back against Professor Pinker a bit, if we don't have policies and guidelines for responsible use, we're going to get charlatans and rogues who really set back the advances of these technologies. Sorry, that was a long answer to a short question.
Great answer.
Okay.
Thank you. How can policymakers, scientists, and ethicists work together to create regulations that balance innovation in genetic engineering with ethical safeguards and public trust?
Pardon me, without knowing that question, I kind of answered it previously. So, there's an interesting history, which is when the Human Genome Project was being envisioned, which is now, around the same time as the Nash story, there was a kind of a fork in the road about whether to include people doing ethics in, the design and carrying out of that work. And Francis Collins, who I mentioned to you before, not helping me, unfortunately. I think I swallowed the water wrong. Rather than giving me more, just going to make me cough more. So Francis Collins was a very, progressive thinker in this way, and realized the value of having people like us in the room with the scientists. And that has been now kind of the model. We even call it embedded ethics. So we have people who do the kind of work I do, working side by side with people in laboratories and clinics, as a way of helping really, as the work unfolds, helping to guide it. So I think we're in up till this point in a good place. You know, all bets are off about what's happening at the moment.
You touched on this a little bit in your presentation. With gene editing technologies advancing rapidly, what ethical considerations should be prioritized to ensure tools are used responsibly in medicine and reproductive health?
Yeah. So, yeah, I did touch upon it. There's an interesting discussion happening in my world and in the policy environment about what had been a very clear, bright line about not doing modifications that cross the so-called germ line. Now we talk about it as heritable human genetic modification. So if you modify an embryo at the stage I showed you on the slide, and that embryo is implanted and results in a child, that child, if he or she reproduces, will pass on those modifications because all the cells in the body have been modified. We also can do gene therapy at the somatic level, so it doesn't get into the sperm and eggs. And so there has been a long-standing bright line, like we will allow genetic modification of somatic cells, but not of germ cells. I think we're now having a conversation about whether that bright line needs to stay so bright. Not because we didn't think it was important, but because the reasons we thought it was important was about uncertainty, safety, risk. But the tools are so much better and so much more precise, and the use cases seem so much more compelling, like Huntington's disease. If you could modify Huntington's disease in a way that it would no longer be in families, wouldn't that be worth doing? If we could be sure that it would not unleash some unexpected consequence. And so we're now starting to have a conversation about a heritable genetic change. Now, what's interesting is if you were to say, well, do we do that now? The answer is, actually, we kind of do in the notion of vaccination, because we do an enhancing kind of modification in people that can, it turns out, be passed on in some cases. And so there's even a conversation about using genetic technologies to do effectively vaccination at the genetic level in ways that would then just live in the organism and be passed on to future generations. So that was a long answer, but we're, I think, headed to a really interesting time when the technologies are so good that we have to rethink some of the, not rethink the ethics, but rethink the place that the ethics leads us.
So how do non-democratic nation states grapple with the bioethical implications of their applications of new biotechnologies? Should we be worried?
Yeah, it's a very good question. So the example that comes to mind, because I just talked about it, is China. And what's interesting about the China story is that J.K. He is his name, announced at a very public international meeting that he had done something that the rest of the scientific community thought was very premature. And there was an interesting pause in the reaction from not the scientific community, but from China, where they were waiting to see, I think, this is the analysis editorializing here, whether he would be lauded as a hero, and how soon can we expect the Nobel Prize, or what happened was he was treated as a pariah. And as a result of his being treated as a pariah, they then treated him as a pariah. So there's still a role to be played. Whatever the world order looks like going forward, there's pressure that can come from the more democratic parts of the world to help bring the less democratic parts of the world into alignment. What's interesting is science is not, it doesn't respect boundaries. And so among the things that we've been trying to figure out is, well, what are the tools and levers that one could use that aren't about China or the US or Europe or Japan or whatever. And there are a few things that actually have some traction, like if you want to publish in the literature, you have to follow certain rules. And everybody wants to publish in Science and Nature and New England Journal and JAMA and all the fancy places. And so they have instituted rules that everybody has to follow. It doesn't matter whether your country requires you to or not. So that's an odd place to land, but we don't have, like we're not going to have a treaty, an international treaty on human genome editing. It doesn't rise to the level of, biowarfare or atomic weapons or something. And so we need to find other tools like that for governance. And there's a lot of effort and work and smart people trying to help use those kinds of tools, I think, to answer that question.
How does the current contraction of federal support for scientific research threaten the field of bioethics?
Yeah, gosh, I was wondering when that would come. So it's 420. Two things I'll say, just not jokingly, but real. I don't get ulcers, thankfully, and I don't have trouble sleeping. But if I did have either of those, these would be the days. We're very worried, is really the short answer. And I'm sure, it feels like an in the weeds discussion, but it's been reported in the last few days. This issue of the overhead costs that the NIH pays to universities like mine is a very real problem. So my institute receives grants, and we actually receive those indirect cost recovery dollars. They come to my budget, so I have to manage that. So I just had my finance person run some numbers. So if we were to have a cap from our current rates, and it's not even been reported accurately. So some of our grants are at 55%, some are at 60-something% because of when they are awarded. But if we were capped at 15, for the rest of the fiscal year, which ends on June 30th, my budget would have a hole of $275,000 in it. My annual budget is about $8 million, a little more. That's a lot of money. The university is a multi-billion-dollar entity, right? I only know my own budget in that level of detail, but the medical school would be, the university would be down about $100 million just for the half of the year, and we would have to fire people. So it is sort of more than just what does it mean for bioethics research, it is what does it mean for the whole biomedical research enterprise. It would be pretty dire. The second part of that is we don't know, nobody knows, what the NIH funding portfolio is going to look like going forward. So I mentioned in passing the largest bioethics funding from the federal government comes from the National Human Genome Research Institute. It's all genetics and ethics, has an interesting history. They could say, tomorrow, we don't want to fund that anymore. We're going to send the money to do something else at NIH, and we would be left with a giant hole. So it's a problem. I mean, I don't know what to say, except we're all waiting to see what happens. I don't think it's going to be better for us. I think we can pretty confidently say that. What's today? Saturday. Monday evening, I'm flying to London to go meet with colleagues at the Wellcome Trust in the UK. So we're going to have to go and find money from funders that are not the US government, which seems shocking to say. But you want to finish? Is that what she's saying? I can't hear.
Yes. So Kathleen is indicating that we need to be true to who we are as a food-based religion, that we need to move over to the wonderful reception that includes two amazingly delicious and gorgeously laid out cakes, wherein we can continue the conversation.
Happy to, yeah.
Dr. Kahn would be available for you to ask some of the questions that we didn't get to. Let's really give Dr. Kahn. Thank you.
Of course. Thank you.
Thank you. You made this very accessible for non-scientist people such as myself, and I really appreciate the way in which you not only framed the issue but delved into it and got us thinking about it. And thank you all for being here. And once again, thank you to the Kiplinger team for putting this all together, and our AV team for their wonderful work. So let's all now go and eat and chat and engage Dr. Kahn.